All right, welcome back, everybody. I am really happy to introduce Irene Chen. Irene is a PhD student in computer science at MIT. She's been named a rising star by University of California at Berkeley, Harvard, and the University of Maryland. I've been consuming Irene's research a lot lately, and I know that you all will enjoy hearing her talk about it here today. Take it away, Irene.
Awesome. Thank you so much for that introduction. I'm thrilled to be here. I really enjoyed Emily's talk just now, and the lineup seems great. I'm just super honored to be included in such an esteemed panel of speakers. Many thanks to my collaborators listed here at the bottom, without whom this research would certainly not be possible. And so I'm giving them a quick shout out as well. So without further ado, let's jump right in. So as many people in this audience are probably aware, machine learning has had great promise in a variety of fields, and one of them is healthcare. So that's sort of my area of expertise, is thinking about how machine learning can be used to help or hurt the delivery of healthcare and the advancement of knowledge in the health, specifically as it relates to human health. And the reason machine learning has been so exciting thus far is for a few different reasons, but mainly that it's been powered by these large observational clinical data sets. So these days, in very specific scope settings, we have found that models can actually beat human experts. Medical imaging tasks specifically, so given a picture, an X-ray, a pathology slide, any kind of ultrasound, given that kind of task, we found that machine learning, computer vision algorithms have done exceedingly well. And as a result, a lot of the regulation around these algorithms is also evolving. In America, the FDA, the Food and Drug Administration, regulates it, and in other countries, they have similar challenges about how to grapple with what kind of algorithms should be approved. Practically, what that means is that you might enter a hospital to get a checkup, to sort of check in on how your health condition is going. And your doctor may use a machine learning algorithm to inform the kind of care you would get. This algorithm has been trained on an observational data set, so maybe all the patients before you have come into this hospital. Plus, is also indirectly based on how those patients before you were treated by the doctors in the hospital and what kind of outcomes they received. What kind of adverse outcomes or positive outcomes they received in response to the clinical care they received from the healthcare professionals. The doctor then takes these algorithmic scores into consideration when determining your patient care, and that's how we sort of proliferate onwards as a result of this algorithm being placed into the context of being used for clinical care. Sadly, or interestingly, depending on how far we get along through the process, we are finding evidence of bias in the health context and in many other places as well. And we want to make sure, first and foremost, that these algorithms aren't perpetuating this inequity. So although algorithms themselves are often inscrutable, we are starting to get more insight into the ways that the bias may manifest. Dermatology data sets, so I mentioned that computer vision tasks, medical imaging tasks have been of prominence in the machine learning community, specifically looking at health clinical tasks. So dermatology data sets that are used to train these deep learning algorithms that can now compete with humans and outperform fellowship trained physicians. It turns out that they've been trained primarily on data sets from fair-skinned patients, which is not good. And another example, we can think about how we allocate resources, and specifically a lot of health insurance companies use what's called care management, so they can call up patients and provide them with extra support from clinical staff and follow-ups following visits. And the algorithms that are used to allocate the care management program slots can be shown to show racial bias. And the researchers from that paper were able to sort of narrow down and figure out that it's because that these algorithms are trained on future cost of the patient rather than future health need, which it turns out that the cost of that a person costs you has to do with other factors besides just whether or not you're going to need that kind of health. And so often these biased results are found through looking at the impact on different patient subpopulations. In my own work, we've been able to look at another task, which is chest x-rays and diagnosing from chest x-rays. So given a picture of a chest x-ray, we can train a medical imaging algorithm to diagnose it and say, oh, this person definitely has a collapsed lung, or they have other conditions. And what we were able to find is that when you split it by different racial groups, different conditions have different accuracies for different subgroups as well. And in fact, most worryingly, we found that underdiagnosis, so you actually do have a condition, but the algorithm says you don't, is particularly bad in sort of underserved populations already. And that's something that we should be certainly aware of moving forward, especially since chest x-rays are often seen as this sort of cutting edge in a place where algorithms can do really well compared to humans. So when I started doing all this research, we found all these bias audits, I read about them, and it turns out like, oof, if only we could do something about this. As it turns out, it's important to keep sort of a larger picture in mind. And mainly what I mean by that is that the entire model development pipeline is not just bias audits. In fact, there's a lot of things that happen before you can even find that there's a bias in through auditing of the system. Really, they're the end of a long model development pipeline. So as a machine learning researcher, I like to think of it in terms of how a model is made from the very beginning, coming up with what problem you want to solve, collecting the data, figuring out what you're predicting in the first place, making the algorithm, and then assessing what happens after you make this, after you've sort of put this algorithm out into the wild. I want to mention that these questions that I've sort of raised and that Emily raised today, and that I'm sure all the speakers will raise later, these questions of ethics and justice sit on a web of other disciplines. So we could think about sociologists, anthropologists, legal scholars. And so there are many other frameworks to think about how to think about and audit this kind of work. But as a computer scientist, today I want to frame this thinking through the machine learning pipeline and thinking about the pipeline through the lens of ethics. And specifically, I want to talk about 3 projects that tackle the pipeline and try to think about how can we inject a little bit more critical thinking about equity in probably a very cookie cutter approach to machine learning, sort of like this is how we're going to crank out models from here, and how we can be a little bit more thoughtful about each of the 3 steps that I've outlined in boxes here. At a high level, we're going to talk about 3 different things. One is when we have a bias audit, so we found maybe there's some bias in an algorithm, how can we start to diagnose the sources of the unfairness? What's going on? What can we do to fix it? The second thing I want to talk about is building in the knowledge of that there exists health inequities already into the algorithm development. So we know that access to care is unequal for different patients. How can we make algorithms that take that into account, as opposed to sort of blindly assuming that everyone has the same kind of access to care? And then the third project I look into is how do we explore how to label conditions for people that might be a little bit hard to tell, or maybe very sensitive, and in fact a little bit noisy. And so this is through the lens of a project that I'm working on in intimate partner violence. All right, let's get going. So the first thing I wanted to touch on is once we've gotten to this pipeline, we're at the very end, we've actually seen the bias audit, how can we figure out what's going on? And in fact, there is a branch of literature, fairness literature, that often looks at maybe 2 different algorithms have a different error rate. So let's say, 2 different subpopulations. Let's say you have group A and group B. Group A is sort of this orangish color, and they have a very low error rate compared to group B, which is yellow and has this higher error rate. So we might say that there's a sort of a bias, or let's be more exact, there's a disparate impact of the algorithm because the 2 are not the same. And we might have a few different hypotheses about what's going on. So if I show this graph to a lot of people, oftentimes, if I were in a room, I would sort of want to make eye contact with everyone, but because of the screen share, I actually can't see anyone. But sort of the first people come up with a bunch of different hypotheses. One thing that you might be thinking to yourself, why would group A have such a lower error rate than group B? Some people automatically go to, well, group B is probably a lot smaller than group A. Maybe there's not as many data points. Maybe group B is therefore not getting very good outcomes, very accurate predictions from the algorithm. And if we just had more data on group B, that would be great. Other potential hypotheses include maybe group B has some more complex patterns. Maybe there's something else going on that we need to sort of be able to analyze, use a fancier deep learning model, and we could really see what's going on there. Or maybe that the measurements from group B are less reliable. Maybe there's something going on there where there's just inherently more less reliable measurements, and therefore that's why this error is going on. So as it turns out, the way I've structured these three possible explanations is that, in fact, these align perfectly with three components of statistical error. And so I'll go through them in a little bit more illustrative definitions in a second, but roughly we correspond these to variance, bias, and noise based on sort of why an error might occur and what is potentially causing it. At a high level, those of you who've maybe seen this in a statistics class or a machine learning class, at a high level, we think of bias, variance, and noise. When I say bias here, I mean statistical bias. And I'll be sure to append that so you don't get confused. But we'll say that statistical bias occurs because the model class that we're using is not sophisticated enough for the data, as opposed to variance, which is when the sample size is insufficient to be able to, for the model to learn from the data, versus noise, which is this error that's independent of model class, independent of sample size, and it sort of relies on the inherent noise, the inherent uncertainty in the data itself. For those of you who are familiar with aleatoric and epistemic uncertainty, this sort of roughly maps here. Epistemic uncertainty is roughly noise, and then aleatoric, we could think of that as wrapping up bias and variance together, although usually it refers to variance as well. It most directly refers to variance. If that was sort of got you a little bit lost, I thought it would be helpful to have some illustrative examples. So you have an algorithm going on. Why could it possibly be unfair? So let's consider fitting a line to this data. We have some blue dots and we have some orange dots. There are not that many orange dots, but there are many more blue dots. We could consider using one model and the data itself comes from a true data generating function. And that means that this is the true line it comes from, but you only see samples from that line because we live in a finite data world. We might want to fit a classifier to this data. We could use one model and learn it, or we could actually use two models. So if we had access, for example, to the group membership, we knew which ones are orange, which ones are blue, we could actually build two models and sort of go from there. But as it turns out, comparing the learned model, so these dotted lines, with the true data generating function, so that's orange and blue, we see that they don't necessarily overlap. And in fact, because of the orange dots, there's so few of them, we ended up with this kind of wonky line. That's just because there are only 5 orange dots. And in fact, if we had more samples from the orange group, this is error from variance, we could have made the models fit each group equally well and reduce the variance for the orange group instead. So variance, just to think about it in your head, is collecting more samples and figuring out how to do that. As another illustrative example, we might have data from 2 groups again. Here we have orange and blue again. However, there's about the same amount of data points here. So not trying to trick you with the number of data points, but an astute observer might notice that even if we fit one model between all the data points, or if we fit 2 models because of the way the data points are generated, that actually the orange dots have on average higher distance from the learned model compared to the blue dots. So you can just sort of see that the orange lines to the learned model are much larger compared to the blue dots. And as I mentioned, those astute observers may notice this is because the orange dots are actually drawn from a quadratic distribution. We were fitting lines this whole time, when in fact, perhaps we should have been doing polynomial regression instead. As a result, the model class is ill-suited for the orange group compared to the blue group, and we would call this error due to statistical bias, and we would recommend changing the model class, meaning not just having straight lines, we could have curved lines, polynomials instead as well. Lastly, as a last illustrative example, we might see data from two groups, but again, same number, not trying to trick you on number anymore. But no matter what data we choose, here we're just going to do one learned model because actually the data generating function is the exact same for both groups. We actually see that the average error for the orange dots is much larger than the average error for the blue dots. And even if we had a lot more data points, even if we used polynomials or linear instead of linear model classes, we would continue to get that kind of difference in errors because the orange group is simply harder to predict. It's sort of spread out more, even if you can imagine we had infinite data. So we would call this error due to noise, and we would recommend collecting more features. Maybe there's like a hidden second dimension, a third dimension, fourth dimension beyond that would allow us to be able to model those data points more accurately. So I sort of have walked you through how to think about bias, variance, and noise in the context of, unfairness, discrimination, and part of what I've been looking at is figuring out ways to detect this, to take some bias audits, to take a model that we know is discriminatory and figure out, okay, why is it? If we had that $1 million grant, because there's millions of dollars floating around to solve these kind of problems, but if we had $1 million, how would we allocate it appropriately? How do we make sure that we are doing it in the right bucket and we're not wasting our resources? So as a quick taste, one way we could do it is that if we wanted to detect if variance was at fault, we could do what's called sort of a bootstrapping curve fitting approach through the observation that these type 2 learning curves fit an inverse power law, which means that as you increase the amount of training data, empirically it's observed that your test error will fall in an inverse power law. So we can fit actually a line to our data by subsampling the amount of data that we have. We can't get more data necessarily, but we can get statistically fewer by pretending we have fewer and mapping that line out. And in fact, if this asymptote, so this plus gamma term, is not 0, then we know that even if we had infinite data, we wouldn't go to 0 error. And for two groups, if we had different gamma terms and we knew the infinite data for both groups, we still wouldn't get 0 error. Therefore, it's not always variant. So that's a sort of one check you can use to figure out which bucket it is. So I would say the takeaway from here is to think about if you have a bias, if you have an algorithm that's biased, if you find something going on, something fishy going on, this is sort of one framework. There may be others, and I'm sort of working on that as well, but you can start to think about why and start to do robustness checks to figure out what's going on, as opposed to sort of, running to the headlines and saying, oh, this algorithm is biased. The next step would then be, oh, it's biased because data set size. It's biased because the model we're using is incorrect, is an incorrect kind of complexity, or it's because the noise from different groups is different. So thinking about the why and the how allows us to move beyond the bias audits directly and start to make changes maybe upstream in the algorithm. So by using one framework, we can better diagnose sources of uncertainty and then act accordingly. All right. I'm gonna whiz through this because I don't think I was, well, we'll see how, we'll definitely have time for questions at the end. All right, next up, I want to talk through, this is a very fancy sounding title, but essentially I want to walk through an example of how to incorporate the ways we think about systematic health disparities in the algorithm development segment. So sort of one step above, how do we start building that into the algorithm directly? In the previous case study, I talked a little bit about noise and actually sort of why measurements for different groups might be different. And in fact, this is like a whole area of research in itself. So there are systemic health disparities that exist and they're documented and they happened well before machine learning entered the picture that can in fact affect the observations for different groups differently. So examples include disparities to access and care. Maybe the hospital is not geographically that close to you. Maybe financially you're concerned about how much that will affect your family and you. Maybe you have a systemic mistrust in the healthcare system because of historical inequities. These are all very valid ways that you may feel that a patient may be suspicious or unable or unwilling to interact with the healthcare system in the same capacity as other patients. Similarly, there are disparities in treatments. This can mean that two people with the exact same symptoms may get treated differently, as is often the case with women in pain medication compared to men in pain medication. Or it could mean that two people who have the same condition would like to get different treatments, but are in fact treated the same. So this could happen in the case where symptoms for one patient may mean that they're much more severe than symptoms for another patient, but there's sort of the medical knowledge hasn't quite caught up in the same way. And then lastly, there are disparities in outcomes. So this is related to life expectancy, maternal morbidity, all kinds of different composite scores we can look at, outcomes, and figure out what's going on, why are there disparities here, and having that be part of the pipeline as well. So lots of reasons why there could be noise. But today, I want to talk through a case study, which is when we are trying to learn about the disease and when it can be actually heterogeneous, meaning that there's a disease, it's called a certain name, but it's actually many different smaller diseases that we sort of lumped together. So asthma is known to be many different types of diseases. You would just call it asthma as a bucket term, similarly to autism. And then even heart failure is in fact at least 2 different diseases, depending on what parts of your heart is actually breaking down, and possibly more than 2. We often want to learn about how to subtype different diseases based on the data that we observe. And the data we observe is pretty sparse. People don't live at the hospital all the time. We're not constantly poking them for blood. And also different patients come in and out and they're sort of living their lives. So it can be irregularly spaced. And it's also multivariate, meaning that there are many different biomarkers that we're keeping track of. So different, like your cholesterol or your A1C level, we're just sort of keeping track of a lot of different values. We might be interested in predicting an adverse event. So here there's sort of a ominous red X. We could think of that as patient mortality. We could think of that as a heart attack. We could think of that as admission to the hospital. Pick your favorite adverse event, and we might want to predict in the future what's going to happen to this patient. We could also, though, learn about the general progression. So figure out over time, how is this patient going to progress, to give a better sense, to give a better understanding of what is going to happen to these patients moving forward. And one way of doing that is that we could align by the adverse event. So we could look at the progression right before the adverse event and see what happens 1 year, 2 year, 3 years before your adverse event. The problem with this is that now we've actually lost 2 of the patients because they didn't have an adverse event at all. They were just sort of in the study. We just sort of had access to their data set. They were diagnosed with the condition that we're concerned with, but they actually don't have an adverse event at all. So now we've had to throw out almost half of our data set. The other way that people often do it is that they align by diagnosis. And when they figure out, okay, when you get diagnosed, what happens 1 year, 2 years, 3 years after you get diagnosed? And this is probably the most commonly accepted way of aligning data, observational longitudinal data sets in order to study disease progression. Specifically, what I'm often interested in is subtyping, disease phenotyping of diseases. Problem is that the diagnosis term could be left censored. And what I mean by that is that there may be something going on before they come in that makes the data that happens there hidden. And as I mentioned, there are many different factors why patients might have different access to care, and therefore left censoring in the statistical sense would occur. We, for our project, developed what's called a deep generative model, and that allows us to map patients into a low dimensional latent space. And what that means is that we could sort of take all this multivariate, sparse, messy, misaligned data, and we can just sort of project it down into a lower dimensional latent space. I'll get to how in a second, such that if 2 patients are really close to each other, then we know that they're probably the same subtype and they're probably manifesting the disease similarly, versus compared to another disease very far away, and we might say that another patient very far away, and we might say that that patient is probably from a different subtype. And we developed a deep generative model that specifically tries to correct for this alignment issue. So here we have patient B, and B plus is just an alternate reality version of B, where B came in a little bit earlier. And in fact, she got a whole other measurement, this orange dot, that was able to be measured, but still in our latent model, these patients are basically the same. And so they should actually be projected pretty similarly instead, as opposed to patient B and D, who are very different and we could say are very far apart. Without getting to, I'm happy to talk about the technical details, but at a high level, we were able to sort of recover clinical subtypes as well. So we looked at heart failure patients and Parkinson's patients and figure out that there are different subtypes. Once we've corrected out for alignment, we can start to go beyond for heart failure, the standard dichotomy of the two types of heart failure, and actually discover or suggest a third that could be of interest to the clinical community. And then for Parkinson's, we looked at a data set where there were control patients and Parkinson's patients, and we were able to actually accurately pick out the Parkinson's patients, despite the fact that some of the Parkinson's patients came in pretty early on and could actually look pretty similar to the control patients at a specific time. So at a high level, this project is focused on how can we correct for alignment issues. And alignment here refers to left censoring, which occurs because of, in the healthcare setting, often because of differences in access to care. All right. And so for my last example, I wanted to highlight some of my newer work that I've been working on. And specifically, we're looking at intimate partner violence. I'm going to refer to it as IPV, which is defined as the physical, sexual, psychological, or economic violence that occurs between former or current intimate partners. So it's a big mouthful, but essentially it's a subtype of domestic violence. So domestic violence is sort of all violence that occurs in a domestic setting, but intimate partner specifically refers to between current or previous intimate partners. And the question becomes, how can we think about this pipeline with in the context of intimate partner violence? The intimate partner violence, just as a high level, is a pretty urgent and widespread public health concern. According to the UN, half of all women who are killed globally are killed by either their family or their intimate partners. The CDC estimates that 1 in 3 women and 1 in 10 men will experience physical violence, sexual violence, or psychological violence by an intimate partner during their lifetime. So it's a pretty big deal. I would say that it's definitely not studied nearly enough. And machine learning has sort of started to come into the scene because IPV victims are in the hospital a lot more. There's a lot of data that shows that they come into the emergency room, they get more radiology scans, they have a lot more broken bones. There's sort of data that we can start to observe about what's going on. And some of the work that I've worked on, we can see that you can now start to screen patients with performance that exceeds humans, which is very exciting. But the sort of heart of this IPV problem becomes actually, how do we get labels? How do we figure out who is a victim of IPV? This is a pretty big problem because the biggest barrier to IPV intervention is actually underreporting. So for many reasons, victims are reluctant to, although victims use healthcare services much more often than comparable age or other demographics who are not victims, there's often sort of a stigma against coming forward and telling your healthcare provider because of shame, economic dependency, lack of trust, all kinds of reasons. You don't know what will happen once you say it. So there's a sort of an underreporting problem. And so the purpose of this work was to figure out how can we get labels that we can rely on and be able to therefore roll out further analysis down the road, making sure that the labels we use are not biased against particular groups who might be more stigmatized or less stigmatized, and that are also inclusive of all kinds of IPV victims. This is work that's based on data that we got from Brigham and Women's Hospital, which is in downtown Boston. So there were 3 options for labels we could use. One is ICD codes. So these are diagnosis codes that are logged for billing purposes by the hospital, but end up being very useful for other things as well. And this is based on the clinical staff assessment. The problem with ICD codes is that a clinician has to definitely know what's going on, and the clinician has to remember to log it based on which code. Some of the codes are important for billing purposes, as I mentioned. So like diabetes, if you're getting like an A1C test, you need to say it's for diabetes, and therefore diabetes will definitely be in the record. Whereas other things like lower abdomen pain or something like that, maybe the clinician doesn't quite remember, or they don't think it's relevant for the current situation, so they'll forget to log it. Also, if you don't tell your clinician, the clinician doesn't know, and therefore you don't have the ICD code as well. The second option is patient self-report. So Brigham and Women's Hospital has a fantastic violence prevention program where patients can actually self-enroll into this program, and they can receive resources, legal help, psychological help, follow-up visits, and be able to navigate their situation from with help from experts. And so this is sort of, maybe you could think of a gold standard, like if you're entering this program, you're probably definitely a victim, but it doesn't necessarily catch everyone if they're reluctant to enter a program like this. And then the last label we used is radiologist labeling. So just looking at injuries. So if you look at the middle picture of the slide, this is an ulna fracture, which is one of the bones in your arm. As it turns out, people with ulnar fractures might come in and they say, oh, I fell, but it's very unlikely that you broke that bone in a fall. Just the way that people catch their arms when they fall, it's just almost impossible. And in fact, an ulnar fracture is actually most often caused by a defensive wound, protecting your face or your upper body from someone attacking you from above. And so radiologists who have been trained to look for intimate partner violence victims can look at an X-ray and actually determine from the injuries if there's high suspicion of a victim based on these radiology reports. So there's been a lot of work on ICD codes as labels, and also how unreliable they are potentially. So what we focused on is actually patient self-reporting and radiologist labeling and generating a data set for that. So we collected self-report labels. We partnered with Passageways, which is this domestic violence program, and we screened specifically for victims of IPV. And then we collected all of their data. We extracted their data from Brigham and Women's Hospital. So if this patient had ever been seen at Brigham and Women's Hospital before, we pulled their data, as well as some control cohorts who are age and sex matched, who are not, and who had not entered this program. For the second sort of labels that we use, so that now we're doing two prediction tasks. First one was self-reporting, and the second one, the label we used, is this radiology image. So we took 4 fellowship-trained emergency radiologists. They had to go undergo sessions with domestic violence, intimate partner violence specialists to sort of describe and understand how these injuries might occur. And then they reviewed almost 1,000 records of different patients and looked at all of their x-rays to see what's going on and whether or not this is in fact an injury, and to provide a label from there. So of these 2 sets of labels, we were able to have pretty comparable performance, which means that perhaps self-report label or radiologist label would be appropriate. And then in fact, we were able to detect IPV a median of 3 years before that patient ultimately entered the program, entered the violence prevention program. So this is very encouraging results, because we are able to show that this would be more accurate than using ICD-9 codes, and in fact could be useful for scaling out a system like this in the future to automatically detect future victims of IPV. So to recap, today I outlined sort of 3 projects that seek to address issues of equity along the machine learning pipeline. But there are many steps that I didn't even touch on today. So to those of you who are in the audience, just by attending the session, I'm sure you are, passionate about thinking about computing tools, bringing it into the world, and how to address questions of bias and equity. So I want to challenge you to think about how the pipeline fits together, how all these steps feed into each other, And if you're so inclined to think about machine learning and health specifically, to tackle where you fit and where you can have the most impact in this pipeline, and how you can address the questions of equity that might arise at each step here. So with that, I'll go ahead and pause and take any questions.